Good day. This is the second part of my lecture on the endocrine problems in children. So for today, we will have this disorders of the adrenal gland. So this, of course, this is your adrenals. So these are your adrenals. So you have two, the right and the left. And then these are the areas. Okay, so you have here the adrenal medulla, and then you have your cortex. Okay, so the largest portion, of course, is occupied by the adrenal cortex. And then under the cortex is you have the zona glomerulosa, the zona fasciculata, and then your reticularis. Okay, and then here you have your medulla. So here, as you can see, cortex is about 80%, and then the remaining is 20% for the medulla. So with regards the production, the main secretory products here in glomerulosa, the ones produced is your aldosterone, and then your fasciculata is your cortisol, reticularis are your androgens, and of course in the medulla you have your epinephrine and norepinephrine. Okay, so mineralocorticoids such as your aldosterone is or are produced in the zona glomerulosa, and these are important in helping in the regulation of your blood pressure and also with electrolyte balance. And the glucocorticoids like your cortisol and your corticosterone are synthesized in your zona fasciculata. And what are their functions? So it includes regulation of metabolism and even immune system suppression. And as I said, the innermost layer of the cortex, which is your zona reticularis, produces the androgens, which are converted to fully functional sex hormones. Okay, and these are found in the gonads and also in the target organ. So we all know also that in the adrenal medulla, we have this epinephrine and norepinephrine, and their role in increasing heart rate and blood pressure, constricting your arterioles, okay, for this particular hormones. So these are the functions, okay, of the cortisol. So there are a lot of functions for cortisol. So decreasing bone formation, increasing bone resorption. You have decrease in connective tissue, inhibit inflammatory and immune responses, maintain cardiac output, facilitate maturation of the fetus, increase glomerular filtration and free water clearance, modulate emotional tone or wakefulness, maintain muscle function, decrease in the muscle mass. Okay, so there are a lot of functions of your cortisol. Okay, and aldosterone is a mineralocorticoid. And as I mentioned, it regulates the concentration of both the sodium and potassium, wherein the kidneys will conserve your sodium and it excretes your potassium. And it responds to changes in the composition of the plasma and being regulated by your RAS, no? The renin-angiotensin system of the kidney. So this is how your adrenal hormone, or this is how the adrenal gland secretion is being regulated. So the secretion, no, so this one, no, the secretion of your cortisol is regulated by the classical hypothalamic pituitary, okay, hypothalamic pituitary adrenal feedback system. Okay, and then the major determinant that controls the secretion of this cortisol is your corticotropin or your ACTH. Okay, and in normal subjects, there is both pulsatile and diurnal. So you call that circadian rhythm. Okay, so there is both pulsatile and diurnal secretion of your corticotropin or your ACTH, which causes secretion of your cortisol. So therefore, an increase in the serum cortisol concentration will inhibit the secretion, no, of your CRH or your corticotropin releasing hormone and your corticotropin. So conversely, any decrease in the serum cortisol concentration may result in the increased secretion of your CRH and your corticotropin. So if the adrenal glands are unable to respond to stimulation of your corticotropin, decreased serum cortisol concentration will persist. So any severe physical or emotional stresses here, no, these stresses may stimulate secretion of your CRH and corticotropin. So therefore, releasing in large increase, no, in your cortisol formation, okay, or in your cortical concentration. So under these circumstances, increased serum cortisol concentration do not inhibit the secretion of your CRH and or corticotropin, and thereby, so it allows large amounts of your cortisol to be secreted until the stress subsides. Okay, and also your ACTH or your corticotropin stimulates the secretion of your adrenal androgens, no, your anabolic and sex hormones from the adrenal cortex. But actually, these androgens do not inhibit this corticotropin secretion. Okay, and also aldosterone secretion is predominantly or primarily regulated by your renin-angiotensin system. And also your aldosterone, the secretion of your aldosterone is also stimulated by high serum potassium concentrations. No? In cases of hyperkalemia, this aldosterone may be stimulated, the release of such, no? And to a lesser, just a lesser extent by your corticotropin. So excessive aldosterone production or even excessive renin secretion leads to excessive angiotensin and aldosterone production. So as an effect, it can cause your high blood pressure. Okay, so that is how the adrenal gland secretion is being regulated. So when we talk about adrenal dysfunction, so it could either be a decrease in its function or increase in its function. So when we say decrease, this that is something to do with the adrenal insufficiency, wherein there is low cortisol, or also that's aldosterone. No, that's it's not aldosterone, that's aldosterone. So like in patients with Addison's disease. Increase in function, it could be found in Cushing syndrome, wherein you can find high cortisol in patients with hyperaldosteronism, when there is high aldosterone, and pheochromocytoma, wherein there is increase in your catecholamines. So what are the causes of your adrenal insufficiency? So we have this congenital adrenal hyperplasia. You have Addison's disease. Infections like TB and sepsis can also cause this insufficiency, and adrenoleukodystrophy can also cause this adrenal insufficiency. Okay, let's have first your Addison's disease. So it is autoimmune. It could be isolated, or it can be associated with other autoimmune diseases. And most often patients may present with tiredness, weight loss, skin, no, very characteristic skin pigmentation. And aldosterone and cortisol here is low, but the ACTH, and both the ACTH and the renin will be high. So there is low sodium and high potassium. So remember, your high potassium can stimulate the release of your renin. Okay, and then what you can do here is you do your ACTH stimulation test and also determine presence of your adrenal antibodies. And of course, because of the low cortisol, low aldosterone, so you need to replace, okay? You need to give both of these hormones. So with regards to symptoms and signs of your primary adrenal insufficiency, the most common manifestation is weakness and fatigue, okay? And then most patients, 98%, may have hyperpigmentation of the skin, unexplained weight loss, anorexia, nausea and vomiting. Okay, there is decrease in blood pressure. Okay, you have to remember this. Sodium is low, potassium is high. Okay, so that is characteristic for primary adrenal insufficiency. So note here the skin pigmentation in this patient, okay, and then you have here this deposition, no, okay, of the nails, and then you have here, look at the teeth also, the patient. Okay, this is hyperpigmentation. So these are the manifestations: hyperpigmentation, dehydration, hypotension, okay, hyperkalemia, both hyponatremia and hypoglycemia. So these are the very specific manifestations of patients with primary adrenal insufficiency. How about if if the patient goes into Addisonian crisis? So this is actually a life-threatening complication wherein the patient may develop severe type of dehydration because of the frequent vomiting and episodes of diarrhea. And then because of the losses, then patients may go into shock, okay? And then with severe hypoglycemia, and then all the manifestations of shock, no? And the treatment, of course, because there is dehydration, you need to rehydrate your patient, hydrate your patient, and you can give your IV hydrocortisone. So symptoms and signs of the crisis, okay, so you have your dehydration here, okay, and then of course would lead to hypotension and shock, fever, so because of the volume depletion, also nausea, vomiting, weakness, and hypoglycemia. Okay, so we have here your congenital adrenal hyperplasia. So this is another metabolic problem that can be screened during the neonatal period. This is part of your neonatal or newborn screening program. So this is actually a deficiency of not only one deficiency of a particular enzyme in steroid synthesis. Okay, there are actually 5 subtypes, no, of this congenital adrenal hyperplasia, but the most common cause, I mean the most common form, is the one that that is regulated or being catalyzed by the enzyme 21 hydroxylase, no, in the area where this particular enzyme will act. Okay, and it is autosomal recessive, and there is equal male and female ratio. So actually, when you talk about steroid synthesis, so we have different enzymes that will be involved. Okay, so we have this actually 5, no? Actually 6 now, because the first one during the cleavage, there's desmolase here, and then 3 beta hydroxysteroid dehydrogenase, the 17 alpha hydroxylase. The one that I've said, the beta hydroxylase, in the 21 beta hydroxylase, 11 beta hydroxylase, and your aldosterone synthetase. So these are the areas where your congenital adrenal hyperplasia may occur, no? But the most common cause is still your 21 beta hydroxylase. Okay, so the clinical symptoms of CEH, no, would result from the deficiency of all these hormones. Okay, and those, no, because of the deficiency, there would be produced in excess. So the function of your 21 hydroxylating, this one, no, the function of your 21 hydroxylating cytochrome 450 here is deficient. Therefore, okay, I'll just make, okay, wait. Okay, so this could lead, no, because of that, because of the block here, because when you say enzymatic block or a metabolic block, so if there is a block in this area, there would be accumulation of the substrate prior to that. So therefore, there would be accumulation of your 17 hydroxyprogesterone. Okay, and any excess, no, of this 17 OHP, so you call it OHP, is being shunted into the intact androgen pathway. Okay, wherein, so instead of going to the formation of your cortisol, it will be shifted towards this area, wherein instead of being acted upon by the 21 beta hydroxylase, it will be now catalyzed by the 1720 lyase enzyme, converting your 17 hydroxyprogesterone to androstenedione. So this androstenedione is a major adrenal androgen. Okay, so therefore, because of the deficiency of this cortisol and then the excess in the formation of your sex hormones, then patients would manifest those clinical features that I will be discussing later. Okay, so this mineralocorticoid deficiency is actually a feature, no, of the most severe form of the disease called salt wasting congenital adrenal hyperplasia. Okay, so that's one of the areas that you need to look at, no, when you manage patients with CEH. So a complication of this could be death, no, because of severe dehydration. Okay, so this one, the same, no? So a block in your 21 hydroxylase, there will be accumulation of this, leading to the formation of this hormones, no? Your adrenal androgens. Okay, so this one, so there's no formation of this. Instead, it moves towards this area. So your okay, so this is normal, no? So with in your adrenal gland, so there should be a balance, okay? Because of the presence of those 5 enzymes. So all of this must be produced. So there should be formation of your cortisol and aldosterone and your androgen. So, but because there's a problem here, no, in the formation of your cortisol, or even here, no, so therefore all this, okay, all the substrates here will go towards this area. So there would be an overflowing androgen formation. Okay, so in patients with CEH due to 21-hydroxylase deficiency, it is found in 90 to 95% of patients with CEH, okay, the one that has this defect. And the females are affected with severe and classic 21-hydroxylase are exposed to excess androgens prenatally, no? Even during the time that the baby is still a fetus, no, it's being exposed to that. So therefore, they will be born with virilized external genitalia. So this could be the presentations of your 21 congenital or hydroxy congenital adrenal hyperplasia. So there could be ambiguous genitalia in girls. So because it's salt wasting, there's dehydration and shock. So they usually manifest with hyponatremia, hyperkalemia, hypoglycemia, and hyperpigmentations. So this is an ambiguous genitalia of a female baby. Okay, the same. This is a female one. Okay, so look at that, no, because of the increased androgen production. Okay, the same, no. So you might be seeing this in a patient with congenital adrenal hyperplasia. So when you talk about internal, okay, internal genitalia, because what I showed to you was the external, no? So in contrast to the virilization of the external genitalia, the internal female genitalia, which is the uterus, the fallopian tubes, the ovaries, they may develop normally. Okay, so actually females with CEH, they do not have the testes. So therefore, they do not produce the the anti-Mullerian hormone. So which is actually, this EMH, this anti-Mullerian hormone actually is being produced where? In your testicular Sertoli cells. So therefore, the internal female structures are just Mullerian derivatives and are not androgen responsive. So therefore, the affected female born with virilized external genitalia may have normal female internal genitalia and still have the possibility of normal fertility after the genital ambiguity is already repaired. So there is still hope, no? So it can still be repaired, no? How about boys with congenital adrenal hyperplasia? So sometimes it's unrecognized at birth, no? Because if you look at their genitalia, they are normal. What they usually present early is salt wasting crisis. So they may have manifestations of dehydration, hypotension, hyponatremia, and hyperkalemia. And later in childhood, they may present with early pubic hair. They may present with symptoms of precocious puberty and even accelerated growth. So in terms of fertility, no, males with CEH, particularly if they are poorly treated, may have reduced sperm counts. Okay, they may have low testosterone as a result of small testes, no, due to the suppression of the gonadotropins, and sometimes the internal testicular adrenal rests. Okay, so because of these complications, it may result to diminished fertility. Okay, but in females, difficulty with fertility in females may arise, no, for various reasons. Okay, so I've mentioned that earlier that they may have normal fertility once the ambiguity can be cleared, no, but some reports would say that there could be reasons for the difficulty in fertility of this female with CEH. No, that would include an ovulation. They may have secondary polycystic ovarian syndrome. They may manifest with irregular menses, non-suppressible serum progesterone levels, or an inadequate introitus. No, so actually, compared to normal individuals, fertility is also reduced in salt wasting 21 hydroxy deficiency, no, beta hydroxy hydroxylase deficiency. Okay, so how about the non-classical CEH? So this is having problems with the residual enzyme activity. So they are usually non-salt losing, and they may present late in childhood with precocious pubic hair and or clitoromegaly and even accelerated growth. So they may be present in adolescence or adulthood with varying virilizing symptoms that would range from oligomenorrhea to hirsutism and infertility. So this is a non-classical CEH. Okay, and how do we diagnose? So of course, since it is salt losing, so you really have to determine the electrolytes, check for metabolic problems in the baby, in the baby or in the child, no, and characteristically they have this low sodium and very high potassium, and they have hypoglycemia. They may be presenting with high uric, high creatinine or even BUN because of the dehydration, elevation of the plasma renin and ACTH levels, low cholesterol, high in 17, high OHP, high androgens. No? So if you just remember, if you just understand the pathway, you will be able to know, no, or understand this diagnostic criteria in your CEH. No, so you can have low aldosterone. Okay. Okay, you can also check for chromosomes in some of the patients and do your pelvic ultrasound. So to manage these patients, you give your hydrocortisone. Okay, your cortisones can be given, and then you need to hydrate your patients. And then, as I said, you need to for the ambiguity, no, of the external genitalia, surgery, no, may be indicated. Okay, so let's now proceed to another one, no, which is Sear-Cushing syndrome. So this is a result of, or this may be a result from increased adrenocortical secretion of your cortisol. So these are the following causes. It could be an ACTH secreting tumor of the pituitary, so we call that Cushing's disease. Excess secretion of your cortisol by a neoplasm found in the adrenal cortex, ectopic secretion of your ACTH by a malignant growth outside the adrenal gland, and excessive or prolonged administration of steroids. So this is what you call iatrogenic cause of your Cushing syndrome. So these are the manifestations of your patients with Cushing syndrome. So there might be truncal obesity, moon fascias, okay, buffalo hump, so everything here, no? So there might be a lot of acne, and then hirsutism, no? There are hairs here, okay? Because of the truncal obesity, there would be abdominal striae, manifesting with hypertension, some psychiatric disturbances because it could be the appearance or even hormonal, osteoporosis, amenorrhea, and even diabetes. So these are the, in terms of the percentages, in terms of their signs and symptoms. So the most common is still the central obesity, followed by hypertension, glucose intolerance, hirsutism, and so on. Okay, so these are the common signs and symptoms in patients with Cushing's syndrome. Okay, so this is an example of a patient with Cushing's syndrome. Okay, look at the obesity, truncal obesity. So this is the characteristic fascias, very round. Okay, maybe you cannot find hirsutism here. And then these are the abdominal striae in Cushing's syndrome. Okay. So it just compared the pre-treatment and post-treatment in patients with Cushing's. So treatment, of course, you need to treat the underlying cause. Look for the underlying cause. And then if there is tumor causing the syndrome, then you do the surgery. Okay. Let's have now this diabetes mellitus. Okay, so to review your anatomy, so your insulin is secreted by the beta cells in the pancreas, whereas the alpha cells are the ones secreting glucagon, no? And your pancreas would secrete 40 to 50 units of insulin daily in 2 steps. Okay, the first is secreted at low levels during fasting, so we call that basal insulin secretion. And then there could be an increase in your insulin levels after eating. So that's postprandial, okay, increase of your insulin or your release. And an early burst of insulin occurs within 10 minutes of eating. So that's why you need to let the patient fast before taking the blood sugar. Okay. Okay, so we all know that diabetes could affect all the metabolism of your foodstuffs, no? Your carbohydrates, proteins, and fats. Insulin is very important, especially with regards carbohydrate metabolism, no, in your glycolysis, and also with fat metabolism, no, wherein it promotes lipid synthesis, it promotes triacylglycerol synthesis, and even cholesterol synthesis. Okay, so any deficiency of this insulin may lead to abnormality of this of the metabolism of these foodstuffs. So we have different types. So we have the type 1. It's the autoimmune one, and this is characterized by the destruction of the beta cells of the pancreas. So therefore, most often they have absence, no, or deficiency of insulin. So this is the type of diabetes that would require a daily insulin administration. So it may occur at any age and usually appears below 15 years old. Okay, so it occurs in 1 in 500 to 600 children. So it's a little common. And this results from autoimmune destruction of your pancreatic cells that produce the insulin. Okay, so therefore you have this insulin deficiency. When you say insulin deficiency, you really need a daily dose of that hormone. As we all know, again, it regulates glucose metabolism, no, because it's very important for all these functions. And then the type 2, it's non-insulin dependent. Okay, so it may be caused by a disturbance in insulin reception in the cells, decrease in the number of insulin receptors, maybe loss of beta cell responsiveness to glucose, leading to slow or decreased insulin release by the pancreas. It is diagnosed later, no, after 40. And it's actually, it's an interplay between the genes and the environment. No? So it's a common for overweight individuals. So with usually patients here, it's not really completely deficient. They may have some circulating insulin present. So some patients may not require insulin. So you will just, or some patients may just require oral hypoglycemics. So with regards to blood glucose level, you will be able to determine this very high blood glucose level. So because of the presence of, no, it's still nutritional, okay? So nutritional, deficiency of your insulin, sometimes or most often, it can be triggered by an infection, okay? Stress, okay? And then how about if patients may go into low blood glucose level? So if you have a little food, starvation, no, and then too much insulin, and okay, so more of the exercise. So these are the symptoms, no, when one is having hyperglycemia, extreme thirst, frequent urination, so polyuria, polydipsia. Okay, because of that, there's dry skin, always hungry, no, so you have polyphagia, and then all this, no. And then when you have hypoglycemia, so it's you can also have the symptoms: shaking, fast heartbeat, sweating, anxiety, dizziness, hunger, okay, impaired vision, weakness, fatigue, headache, and irritability. So this could be some of the symptoms if you have low levels of your sugar. So what could be the long-term complications of diabetes mellitus? So there might be cardiac complications. No? So patients may develop what you call this, especially, you know, with comorbidities, no, diabetic, you're already diabetic, and there's familial dyslipidemia, so there's a risk for developing atherosclerosis. So that atherosclerosis will eventually lead to heart attacks, no, or myocardial infarction because of the constriction of the blood vessels, no, because of the accumulation of this macrophages, accumulation of these foam cells in the arteries. Okay, and then as a consequence, it may even lead to stroke. Okay, and then poor wound healing. And then this is a multi-organ, it's a multi-system problem. So patients may have this retinopathy, there would be nephropathy, they may have neuropathy, and so on. Okay. So in children, how is diabetes caused? Okay. So the actual cause actually is a little understood. Okay, but still genetics, no? It's more the genetics being triggered by the environmental factor. So therefore, it is still an interplay between the genes and the environment. Okay, so almost the same with adults. They may exhibit a lot of symptoms that could warn that diabetes can that has developed in the child. So there might be yes, you have the polyphagia, polydipsia, okay, weight loss, and then tiredness. No, why is it that there's weight loss or or decrease in the muscle mass, no? Because if you don't have insulin, there would be increase in the fatty acid oxidation, increase in your lipolysis. So there will be loss of the muscle, okay, or even weight loss in general. And of course, you have this other specific symptoms. Sometimes these are not manifested by the child, okay? We see patients with diabetes who comes into the emergency room with sudden onset of loss of consciousness, okay? And then when we check, the blood sugar is really high, no? So they usually present as having manifestations of diabetic ketoacidosis. And the most common trigger for diabetic ketoacidosis is an infection. Okay, so the same, no? So they have all these symptoms, almost the same with your adults. So I've mentioned about diabetic ketoacidosis. So what is the pathophysiology of this diabetic ketoacidosis? Of course, if there's no insulin, there would be increase in the movement, no, of your free fatty acids, okay, because there would be what you call this, there would be increase in the oxidation, because if there's no insulin, there would be increase in your gluconeogenesis, okay? So there would be increase in the oxidation of your acetyl coenzyme A from your in the partition, no? Because in your glucose metabolism, your pyruvate, no? Your pyruvate will go towards the formation of your acetyl coenzyme A. And then your acetyl coenzyme A will have this partition, whether it goes towards the citric acid cycle or it may go towards the ketone body formation. So if there is increase in your fatty acid oxidation, then there would be increase in the because the citric acid cycle cannot keep pace with the increased outflow of your acetyl coenzyme A to produce your ATP. So therefore, some of this acetyl CoAs, so there will be lots of this acetyl CoAs that goes towards the ketone body formation or your ketogenesis. So as an effect of your ketogenesis, there would be release of your ketone bodies, such as your beta-hydroxybutyrate and your acetoacetate, okay? And that contributes to the manifestations of your diabetic diabetic ketoacidosis. So patients may have manifestations of metabolic acidosis. So if there's no insulin here, there would be increase in glucose. So what will happen if there is increase in glucose? There would be increase in the release of your acetyl coenzyme A, and then more acetyl coenzyme A going to lipolysis, and then your lipolysis will lead to ketone body formation, increase in your activity in your ketoacidosis, your ketogenesis, sorry. And then because of the lipolysis also, it can lead to cellular hunger. That's why patients usually has excessive intake of food. No, they have this polyphagia, and then because of the lipolysis, so there would be weight loss. And what about if there is marked hyperglycemia? It can cause osmotic dehydration because of the increased amount of glucose. So what will happen, this can cause osmotic dehydration, and that osmotic dehydration would lead to glucosuria, no? Because of the, because of the increase in sugar on your glucose, it can cause osmotic diuresis and then leading to polyuria. Whereas your osmotic dehydration would lead to increase in water intake. So these are the manifestations of patients with diabetes mellitus and how your diabetic ketoacidosis can happen. Okay, so we have these manifestations, ketonuria, metabolic acidosis, in order to release, as a compensatory mechanism because of the increase in the levels of your acid, that is the compensatory mechanism of the lungs to increase, that's the deep breathing of these patients with diabetic ketoacidosis. You call that Cosmos respiration. And because you're because of the increase in the ketone bodies, so your acetone may be released from the lungs, so that's why you can smell this acetone breath. And then because of your glucosuria, it could lead to osmotic diuresis. Okay, so you have this tachycardia, because some patients may be on metabolic acidosis, so it may even lead to death. So management, so for DKA, because of the loss, okay, because of dehydration, so you need to replace the fluid, okay, ABC, you need to have the airway, the breathing, and the circulation. You give your insulin, and then if there are signs of metabolic acidosis, you need to give your bicarbonates. And then if there are electrolyte abnormalities, like for example, increase in your potassium, so with fluid replacement and the insulin, because with the giving of insulin, it will decrease the level of your potassium. So there is also one terminology, you call it Somogyi effect, wherein when you have too much insulin, there would be a resulting hypoglycemia. So because of that, glucagon will be released. So therefore, the glucagon, when there is high level of your glucagon, it would inhibit the fatty acid synthesis and promotes the lipolysis or your lipid oxidation, and then promotes gluconeogenesis or glycogenolysis. So this, because of this, because of the activity of your glucagon, there would be what you call rebound hyperglycemia, or even presence of your ketosis. So that is what you call Somogyi. So I've mentioned already the long-term complications of your diabetes. So it affects almost all of the organs, so it can lead to vascular, you have your degenerative changes in the vascular system, in the nervous tissues, in the eyes, so this could be the complications of your diabetes mellitus. Okay, so how do we treat our children with diabetes? Okay, still, the only certain method is the giving of your insulin, because the type 1 diabetes is insulin deficiency. Okay, because type 1 typically means that the vast majority of the islet cells have been destroyed and insufficient, and therefore there is almost zero insulin produced in those islet cells. Okay, and you can give your fast-acting insulin initially, and maintained with the slow-acting insulin. And also because of the age group, you can have your insulin pumps, because maybe later these children may be taught how to give their own, to administer their own insulin in their body. So good glucose control is very essential in the management of all diabetics condition. Okay, so How about if type 2? No, it's not as common, no, in adults. So treating type 2 diabetes in children depends entirely on how far their condition has developed. So again, it's still, aside from medical treatment, the pharmaco treatment, there should always be a non-pharmacological treatment that would include dietary and healthy lifestyle. No, so an abrupt lifestyle change incorporating a healthier diet and exercise should be done at an early stage. Okay, so that ends my lecture, and thank you so much for your attention. I hope you learned something today.